Perfect. Well, this is a perfect transition to everyone on the call with us. Thank you so much for everyone for your patience and for hopping on with us right now. And you got to see some of our tech support free of charge in this webinar. Today, we're super excited to have with us Dr. Paul Hart, an active volunteer with the Addis Clinics Volunteer Medical Corps and a retired family physician with more than 40 years of medical experience. Dr. Hart attended medical school at Memorial University in Newfoundland and led an extremely storied and decorated medical career. His profession led him to practice all over the world, including in Latin America and in East Africa. Today, we're super excited and honored to have Dr. Hart with us today as he talks to us about headache management and primary care. And Dr. Hart, the floor is yours.
Well, thank you very much. And it's a pleasure to be here and to share this talk. What I'd like to do is give a relatively brief talk about headache and then open this up to questions that anybody has. What I've done initially is just an overview of diagnosing and the basis of the management, but we'll get into more detail from your questions. So what I'm trying to look at today is headache as you see it in your clinic, in your office, as a primary care doctor, not as a specialist. So let's look at headaches overall. Most headaches, 90% of headaches are one of three types: a migraine, a tension type headache, or something called a cluster headache. So with these three types of headaches, if you understand these three, you've got 90% of the headaches that you're going to see in your practice taken care of. That doesn't mean you're going to ignore the rest, but this is the vast majority of headaches. So let's start off with migraine. So let's look at what is a migraine headache. Everybody talks about a migraine, but there are a number of features of migraine which differentiate it, which make it unique from other headaches. One, you get recurrent attacks. It's not just one headache and that's it. You don't have another one. Most migraines are one-sided. Doesn't have to be one side usually or the other, but they're usually one-sided. The person who gets migraines on the left usually always gets them on the left side. And if you ask them what the headache is like, describe your headache, please. It's a throbbing, almost like a pulsing type of headache. Additionally, if you can say, what else do you have when you have your headache? People say, I'm nauseated. I'm vomiting. The light bothers me. Sound bothers me. Just a very interesting feature about the light. This is a little bit of diversion. There's a doctor in Harvard in Boston who tried to answer the question, what is it about light that makes migraines worse? If somebody has a migraine, they often say, I want to be in a dark, quiet room. I don't want to go outside in the sunlight. I don't want to go into a brightly lit classroom. And it turns out when he looked at all the spectrum of light, most frequencies of light stimulate our brain, which means that if you've got a headache and you stimulate the brain, it's going to make it worse. Interestingly, there's a very narrow frequency of the green light within the green spectrum, which calms the brain. But the rest of the light stimulates. So if you've got a headache and it's a migraine and you go outside, most people will say, hey, I don't like it here. Now, what are the triggers? Why do you get a migraine? Sometimes we don't know, but the usual cause, stress. Somebody's having a very stressful day at work, at school, at home with a friend. That can be a trigger. For women, it's the monthly cycle. Sometimes it's visual stimuli, looking at something. It can be a particular picture, a series of pictures, an image that for whatever reason triggers a migraine. Some people tell you that they can tell they're going to get a migraine by the weather change. My wife, who happens to get migraines, noticed that if we're getting a rain front coming through and it's going to rain, she knows that she's more likely to get a migraine than not. Now, there's certain nitrites which are put in foods to preserve them. Wine often contains nitrites, at least in the United States, or some foods do as preservatives, and people who take foods with that in can often trigger a nitrate. Aspartame, which is a sweetener, can in some people. And finally, if people don't get the sleep they need, you're up during the night because of phone calls or somebody in the family is sick and you don't get a good night's sleep, your chances of getting a migraine are increased. But even with all these triggers, you're going to interview somebody who says, you know what? Nothing is going on. I was feeling great. None of these apply to me, and I still got a migraine. Now, the next type of headache, which includes this vast 90%, is a tension type headache. That is usually mild to moderate. It's often both sides of the head. People say, my whole head hurts. You'll see them as in this little picture at the top, the gentleman who is, holding his head and both sides of his head hurt. It's not this throbbing, pulsing headache. And usually a tension headache doesn't have the other features or symptoms that we associated with migraine. The nausea, the vomiting, going out in the light and making it worse. It doesn't mean it couldn't have it, but this is an overall general spectrum. So that is the tension types. We've looked at migraine, which is very common, tension, and the final of the 90%, it was what's called a cluster headache. And these are an unknown group, idiopathic mean unknown headaches. Often they are one-sided, like migraines, but often very severe. And they can occur around the eye, above the eye, on the side of the head. And if you look at the person who is having this cluster headache, they are often tearing, their eyes look injected, they've got a runny nose, they're sweating, their nose is congested, they are feeling miserable. It's interesting that these headaches can come on very quickly, but they only usually last 1 to 2 hours, which means that when you go to treat them, some of the medicines that we give, by the time that person would come to you, be half an hour into their headache or an hour, depending how long to get to you. You give them the medicine. You don't know whether the headache is getting better because it's time, it's only going to last 1 or 2 hours, or the medicine worked. Cluster headaches are not near as common as the other two types. Okay, so somebody comes to you with a headache, and how do you evaluate it? What do you, I'm sorry, I apologize, I went forward. What do you do? Well, the first part is you want to make sure that this headache is not due to something that is very serious underlying. It's called like a secondary cause. The main problem is not the headache, whatever that problem is causing the headache. And we'll go into that in a little bit in a minute. And you want to know, therefore, is it a primary headache, a migraine, a tension headache, or do they have something else? And sometimes what can happen is it's not a clear picture. Somebody who has a migraine could have some symptoms of tension headache, or they may come and say, I think I've got a sinus infection. I've got some congestion. And in my training, I was often told that people who come and say, I've got another sinus headache, to think of migraine or tension headaches, that they could be really what is happening, and the person is interpreting it or thinking, because it's in the front of their face, because of the intensity, that it's a migraine. because we usually think of migraines as one of the most intense headaches we can have. Now, one way of helping your patient decide which headache or which type of headache is a headache diary. Now, I don't know enough about the background of your patients. What I would often do is make up the diary for my patients. Take a simple sheet of paper, Monday, Tuesday, Wednesday through the following Monday, morning and afternoon and evening, just 3 columns, and you tell them every day of the week that you have a headache, put a tick in the box. If it was in the morning, if it was at night, and write down a number of how bad that headache was. So I may say that my headache is a number 5 out of 10. The next patient may say, you know, that was an 8, or the other person says 2. It doesn't make a difference because my 5 is always my 5, and the next patient's 2 is always their 2. That is consistent with the patient. So you don't need to worry about what the numbers are, except you know that when you look at the number and you look over the week, you can say, oh my goodness, they're having 2 or 3 headaches in the afternoon, in the evening, in the morning, and they're labeling them as a 2, a 5, an 8. It doesn't make a difference. But that's a good way of you getting information about headaches. And I did that on a regular basis. If you tell a patient to do that and don't provide them with something, there's a good chance they won't go ahead and do it. Better that you just take your piece of paper, you draw it out for them, and you say, please just make the tick mark and put a number into it. That way they don't have to draw something up. You give them the scale, and I don't care if it's 0 to 10 or 0 to 5, 0, no headache, or if there's no tick, there's no headache that day. So that's something that you want to consider doing for your patients. Now, the history. This is probably for you the most important part of the whole evaluation, is taking a good history. There was a very interesting study that was done many years ago in the United States, and I don't know about Kenya, I'm sorry, but they asked the question, once a patient starts speaking, how long before the doctor interrupts them? So I come into you and I say, I'm here because I have an earache. And I start saying, yesterday I noticed a little buzzing, and now this morning I woke up and there's pain, and the pain's been getting worse. How long before the doctor says, oh, was it one side or the other side? Or did you have a fever? Or did you feel nauseated? The answer was 8 seconds. We do not let our patients give us a good history. You should let your patient start after you say, why are you here? And let them go till they finish. Occasionally, you're going to have patients who want to talk for half an hour, forgetting those patients, but wait till the patient is giving you as much of the history as they feel comfortable before you start reviewing that history and getting more details. You may want to write brief notes to yourself if they talk about the headache, if they don't say it was one side or the other, if they were nauseated, if the light bothered them. But don't ask the patient. Let the patient give you that information. The patient will know you're listening to them and will often share a lot of information. So once the patient does that, that's the first and most important part. Interesting. Most people do not need to have any type of X-ray studies for their headache. So if somebody comes in and starts talking about their headache, and you're thinking, as you take your history, this sounds like a tension headache, or this sounds like a migraine headache. If in your mind that is your opinion, you don't need to say to them after the examination, everything, you have to have a CAT scan or an X-ray. Not necessary. You're going to get almost everything you need from an excellent history and a really good physical examination. However, imaging is needed if you think that there's another cause for this headache, not the migraine, not the tension, not the cluster. And that's what we call secondary headache. Excuse me, you have a fever secondary to pneumonia. Pneumonia is the problem. The fever is result of the pneumonia. Okay, after you've got the history that your patient has given you, that you've not interrupted them, what are the history details that you want to know that are going to be important to you to make this diagnosis? And these slides are all available to you. So I don't know if you're taking notes, don't. Everything that I am providing, it's all available, and I will give any more information that anybody wants. It'll be my pleasure. Okay, let's just go through these. How old were you when you started your headaches? I happen to have a granddaughter that was 8 or 9 when she started migraines. Some people are in their 20s or the 30s. There's no magic age. Unlikely to start when you're much older, when you're a senior citizen. It can happen. Do you have a aura or a prodrome? Do you know that headache is coming? I happen to have migraines myself, and I get a funny feeling always in my left shoulder and the side of my neck. When I get that feeling, I know I'm going to start a migraine. And that's the ideal time for me to try and do something about it. Some people will see a flashing light. Some people have a funny smell. It's unique to that individual, and it's usually the same thing over and over again. I've had migraines for I don't know how many years, and it hasn't changed. I always get that same feeling in the side of my neck and my shoulder. Do you want to know how often, how severe, how intense, and how long does it last? So you may, some people say, I get it once a month. You're thinking of a woman when she has her cycle. Or, the only time I seem to get it is after I've worked too long at work and I've had a stressful day. That's the frequency. How bad is it? This is where they use their scale. You can say to them, 0 is there's no pain, and 10, you just can't take it anymore. It's the worst headache in the world. How do you find your headaches? And if you can't do anything about your headache, if you happen to be driving home from work, if you happen to be visiting people and you can't take any medication, how long do they last? Do they last for an hour, 2 hours, the rest of the day? Number of headaches per month is really frequency. And what time of the day, getting back to how often they happen, morning, afternoon, night, do they wake you up from sleep? And how does it start? Is it a little bit of a headache that suddenly builds, or does it suddenly, boy, I've got a headache? What's the quality of the headache? What's the nature of it? Where do you feel it? And does the pain travel anywhere? Do you just feel it in the front of your head on the one side, or do you start feeling on the one side and then you feel it spreads over your whole head? Again, these associated symptoms and abnormalities. Are you nauseated? Are you vomiting? Are you sensitive to light? You want to know about their family. Migraines tend to run in families. I have it, my wife has it, my granddaughter has it. So they do tend to run in families. They don't have to. Now, precipitating and relieving factors. Some people find that I cannot drink, I'm using myself as an example, as I usually do. If I take wine, I get a headache. I know that for me, wine triggers a headache. I avoid wine. I know that if I can catch my headache really early, when I get that feeling on the side of my neck, and I take a combination of a acetaminophen and ibuprofen, one of each, it's going to help it and maybe relieve it. You want to know Does it make a difference if you're lying or standing? Do you only get the headaches when you're sitting down, walking, and you don't get them at rest, or do you only get them when you're lying down at night? What does the headache do to you? Do you have to stop doing everything, or can you carry on? If you're at work, do you have to tell your boss, I'm sorry, I have to get some treatment, or I continue working? If you're at home doing something, if a woman is cooking, taking care of her children, um, being with her husband and sitting, talking, watching, or listening to a program, do you stop or you're not? And have you had any prior treatment? Because sometimes the patient will say, there was a doctor who I saw last year and he gave me this wonderful pill that got rid of it. I forget the name of it, or this was the name of the pill. So these questions you want to cover with your patient. After you've done your history, you want to cover them. And some of them are, frequency, number of headaches. It's sort of repetitive, but it just reinforces the fact that you want to take a really good history from your patient. You don't want to skip over it. Now, I know we're talking time here, and I know how busy all of us are. I don't know how many patients a day you tend to see there. In the United States, an average doctor is seeing 20 to 30 patients a day. You can't spend an hour with each patient. But if a new patient's coming with a headache, it's important we know about that headache. Okay, now you're going to do your physical examination. You've taken your history. By the time I was always told, by the time I have finished my history, I should have a very good idea of the diagnosis. If I don't, I've missed something in the history. The physical examination, I was told, confirms or says no for what my thought is. If I'm worried about a brain tumor, I'm expecting certain findings on my physical examination, usually. If I'm worried about migraine, I'm expecting or not expecting findings on my physical examination. So in my mind, your physical examination, you do it afterwards. You do it very thoroughly, but you're going to, with the whole purpose of saying, I think this patient has migraine. I know usually there are no physical signs or symptoms for migraine that I'm going to find if they did not have a headache at the time I'm seeing them. And I want to confirm that. Okay, we all do our basic blood pressure or pulse. If you've got somebody who comes in with a 250 over 130 blood pressure, you've got a concern that maybe there's a cause for the headache. You're looking for bruits, that sound in the neck, the eyes, the head, which suggested an arteriovenous AV malformation. I've never found one, but you look, and you're checking the arteries in the neck and the temporal arteritis, which is inflammation in the temporal artery, as you know, is a cause of headaches. I've had a number of patients with that. You don't want to miss it. It can lead to blindness if we don't catch it. You want to do a full neurological. A lot of us do a spotty neurological examination. We don't do everything. But in this case, you want to look at each of the cranial nerves. You're testing their eyesight. You're looking their ears. You're testing their hearing. You're testing all their reflexes, all the cranial nerves. You're testing their sensation. You're looking in the background. You're looking at their fundi for raised intracranial pressure. You're looking their ears. Do they have a bulging membrane? Is there something there that could be causing a problem that you can easily detect? And the Rombi and Babinski reflexes. Very important to do, very simple to do. The only problem, the Romberg, easy to do. You're standing, you're making sure they're not going to fall as you tap them. Babinski, you've got to worry about a withdrawal versus a true reflex, because as you know, when we stroke the bottom of the foot, many of us are going to pull back our foot. It's an uncomfortable sensation, and our toe may go up as a reflex for being the pain rather than a true Babinski. So that's just something you have to be aware of. One thing you don't want to do, which I've had happen to me, somebody did a Babinski, thought it was positive, it wasn't, and wants to call in everybody to look at it. You don't want to have somebody stroking the bottom of your foot time and time again. It's not fun. Okay, how do you decide whether you have a high-risk patient for something serious going on or a low-risk patient? So these are the low-risk features. If you're less than 50 and you're presenting with a headache, you're less likely, not that it's not possible, but you're less likely to have a serious problem. If you've had a history of similar headaches in the past, and I'm trying, I hope you can see I've got a bar here on my screen. I hope it's not on yours. But if you had a history of similar headaches in the past, it's low risk. If you've done your neurological exam fully and it's normal, again, less likely. None of these are never, but these are all putting it into an area that you feel more comfortable. You look at the headache pattern and you say, you know, this sounds like tension headaches. They get it after a rough day at work. They get it after they and their children or the wife have had a disagreement. They get it after they've had a certain type of food where they've been out. And again, nothing else on the history. If your patient is low risk, you don't need to do any imaging studies or actually blood studies. You're making your diagnosis of these basic headaches based on your excellent history and your good neurological exam. Now, migraine, interestingly enough, you can ask 3 questions, and this can give you a really good screening. 1, does the light bother you more when you have a headache than when you do not? So if you go out, you know, if we all go outside and it's a bright day, the light, we're going to squint a little bit, the light may bother us. But if you go outside with a headache and it really bothers you, more likely to have a migraine. Does the headache stop or limit or, you know, modify what you're doing? If you're having a migraine, you're not going to be functioning usually as well as if you don't. And finally, are you nauseated or do you feel sick to your stomach? If they answer yes to all of these 3 questions, most likely they're having a migraine. Not absolute, but it's a really good, simple guide. So if you're really rushed and it's one of those days where you had emergency after emergency, you get somebody in and the patient says, doctor, my friend told me I have migraines, and you've taken a history, you've done as much of a neurological as you can do, then you ask these 3 questions. And if it's yes, you're feeling more comfortable that this patient has a migraine. It doesn't mean that it's absolute, but it's a pretty good guide. Indeed, there's an international neurological association which is trying to reach out to pharmacists in many communities, because people often will go into the pharmacy to ask for treatment for the headache. They don't want to bother their doctor. They feel it's something that the doctor doesn't need to do. And they're trying to teach the pharmacist to ask these 3 questions, because if it is, then the pharmacist, okay, I'm going to give you some ibuprofen. I'm going to give you some acetaminophen. They can't prescribe in most countries other drugs, but it's a good guideline. Okay, now what about the other side of the coin? What happens if you're going through your history and your physical, and you can say, this is a patient I'm really worried about. Do they come in with a fever? Meningitis, that can cause a headache. Do they have a history of cancer? My late father had cancer of the kidney that went to his brain near the end. It was metastatic disease. He had headaches. He had a brain tumor. When you're doing your neurological examination, a deficit is a positive finding, if you will. You know, are your reflexes not symmetrical? Is that Babinski upgoing on the right and not on the left? Do they have a positive Romberg? If you look in their fundi, is there signs of raised intracranial practice? Are they older? Are they a 60 or 65-year-old male or female that comes in your office and say, doctor, I'm just starting to get headaches. I've not had it except for minor headaches my whole life. Or I've had headaches in the past, but they're becoming different. I used to get them only after stress at work, and now I'm waking up with headaches. I'm finding them that they're coming during the middle of the day when I'm just sitting around relaxing on the weekend. Does exercise, coughing, sneezing, does some physical activity or make a difference? Does it make a difference whether I'm sitting or lying? Migraines usually don't necessarily, but if you say, I'm only getting a headache when I start to lie back, maybe there's some raised intracranial pressure. The papilledema is an obvious sign. You've looked at their fundi. I found papilledema awfully hard sometimes to diagnose. You've got to have a nice dark room. You've got to have a patient that is cooperating so you can look at their fundi. They're not, withdrawing from you. If the headache is getting progressive and it's atypical, so it's not what you accept, it's not the 3 indicators that we talked about for migraine. It's not what we talked about for tension headaches. If it's getting worse, you're starting to think, there could be something else here. If the eye is painful, if they've had trauma, have they been in an accident? Have they fallen down? Has somebody struck them over the head? Has something fallen on them? And of course, you've got to think of immune system problems. HIV, unfortunately, has not disappeared. And now we also have COVID, of course. Danger signs. In these patients, you become particularly worried that they fall into that 10% group that is not the 3 common headaches, and you've got to do more, and probably in a quick fashion. Okay, so when do you say to the patient, you've got to have a CAT scan? 1, these danger headaches, and again, just to stress, a routine tension, a routine migraine, you don't need anything. Let's move on. So how do you treat it? Education is really important in all parts of medicine. You get a patient who has hypertension. You want to educate them on the fact that hypertension is a chronic condition, that you're going to have to treat it, that you watch your salt intake, all the information which I know you know all about. But you want to tell them about migraine, the type of headache it is, that there are triggers, that there are things that they may be able to do. If you find that wine, as in my case, causes a headache, avoid wine. It's so silly. Sometimes you'll have to say that. Please avoid wine or beer, or whatever it triggers it. If you find that if you're having a disagreement, you may have to say to your family member, dear, let's just take a break. Let's not get into an argument. I don't want to get a headache. Now, treatment of migraine is into 2 parts. I'm talking about acute treatment, but I'll also want to venture right now also into preventative. So in the States, people use the triptans very frequently. They are specific for migraine. They are not pain meds. So it's not the same as giving them ibuprofen, as giving them acetaminophen. It is a specific medication for migraine. And I don't know how many of the triptans are available in Kenya. I think there's 5 or 6 different ones available here. I don't know if anybody has ever shown that one is better than the other. We do know that certain patients respond in a better fashion or more effectively to one than the other. And sometimes you may want to try, if you've given your patient triptan 1 and they say, yeah, it worked, but I still had a headache lingering, you might want to say, okay, for your next headache, I want you to try a different one and see what happens. to use my own family, my wife with her migraines uses a different medicine than I do. We each find that a different one works better. Now, if the patient is vomiting, obviously it's awfully hard to swallow a pill. A lot of the medications come by injection or some by nasal spray. Unfortunately, in the States, and I don't know about Kenya, I'm sorry, they tend to be more expensive. You're getting an injection or a nasal route. But if that's the only way you can relieve a headache, you're forced to do it. And you want to give them something to calm down the nausea. You're worried about abuse of medication, and you can abuse almost any medicine. You can get what's called rebound. So if every day your patient takes a triptan because they think they're getting a migraine, they get a little sensation and say, oh, it may be a migraine. And for a week or 2 weeks, every day they take one of these pills, you can get a rebound. They stop the medicine, they get the sensation that another headache is coming, and they take it again. So you've got to this is part of the education. Make sure you're comfortable that you really are getting a migraine. And often you may want to say, as I try for myself, and not that I'm a perfect patient, when I get that first sensation, I take the acetaminophen and ibuprofen together, and often that's all I need. And I'm not doing that by any means any day. And the final thing is preventative treatment. And the question becomes, when do you consider preventative treatment? And that's a discussion that you have to have with your patient. Some people feel that if they have 2 migraines a week, that is too many headaches, and they don't mind taking a preventative medicine every day of the week to prevent 2 migraines. Other people will say, you know, if I get 1 or 2 migraines a week and I can take something, I'm okay. But if it's 4 migraines a week, no, I don't want to do it. So that is the decision that you make with your patient. 1 migraine a week, usually you don't need prevention, but you still have that discussion. Get your patient's input as to how bad the headaches are, how much it interferes with their life. Because, you know, you and I may be able to say, hey, if I get a migraine a week or 2 migraines a week, I know I can still work. I know I can take something. I know I can function. Somebody else may say, I can't do it. I'm a teacher. I can't be in front of the kids all day. I have a very demanding job that is very precise. And if I have a headache, I can't be accurate. You know, you listen to your patient. And that's it.